Good evening. So trying out a new microphone setup tonight, so if you can hear me, just drop it in the comments that you can actually hear me tonight. Good evening, good evening. I was just saying I'm trying out a new microphone tonight, so let me know if you can actually hear me before I get started. All right, you can hear me, cool. All right. Get started in just a moment. Tonight's topics can be lean mass hyperresponders. Awesome. Yeah, I'm trying a new setup. There was a issue with some of my audio in the past. When I take it from Instagram, upload it to different channels, people always kind of complain that the audio is too soft. So I have an external microphone, but for the longest time, it wasn't really working with Instagram Live. So I found a splitter that would let me actually get the microphone to work. So good. All right. Well, good evening, everyone. Tonight's topic is lean mass hyperresponders. That might be a new term to you, but something I've been seeing, the phenotype at least, for the past couple of years. So as a cardiologist, I'm intimately aware with looking at advanced lipid profiles and looking at advanced risk factors for cardiovascular disease. But when people started to start this kind of keto diet craze or carnivore diet, where they're doing very low carbohydrates, some people's lipid profiles take a significant change for potentially, quote, the worse. But a traditional lipid panel, if you guys have been following me for long enough, you know that it doesn't really predict risk all that well. You have to look at the actual lipoproteins, the ApoB-containing particles mainly. But the lean mass hyperresponders is a phenotype that was initially described in 2017 by a gentleman called David Feldman. He's an engineer by training, very bright scientific mind, and he was doing a lot of kind of biohacking experiments on himself and noticed that his lipids changed this way when he went to a more keto type diet. So they actually were able to get a trial, an observational trial done recently that was trying to look at what were some of the risk factors for actually developing the phenotype. It's still being debated what causes it, and it's definitely being debated, is it something risky to be concerned about? But first off, what is a lean mass hyperresponder? So a lean mass hyperresponder, as the name implies, those people tend to be lean. They usually measure by body mass index, which is a rough estimate of how lean you are. A body impedance analysis would be better, to know your actual body fat percentage, or how much muscle mass you have on a DEXA scan. That would probably be a better metric. But body mass index puts you in kind of a bucket, or you're overweight, obese, or quote, normal weight. The people who tend to be, BMIs of 25, tend to have this phenotype more often. But in the trial, it actually showed that people with BMIs of 21 had the phenotype to the severe degree. The phenotype is defined by a total cholesterol of over 200 milligrams per deciliter, an LDL-C over, I always kind of messed it up a little bit. I'm sorry, no, the total cholesterol isn't in it. So it's the LDL-C is over 200 milligrams per deciliter. The HDLc is greater than 80 milligrams per deciliter, and the triglycerides are less than 70 milligrams per deciliter. So total cholesterol doesn't play a role in it. An LDLc, classically, if somebody's had a heart attack, we're generally wanting to see LDLCs into the 70 or less range. By even the classic guidelines, an LDLc over 190 gives you idea or pause that it potentially is familial hyperlipidemia or a genetic abnormality with the LDL receptor or PCSK9, and these people tend to have very high lipids from early on. The difference with the lean mass hyperresponder is that they would demonstrate that they had normal traditional lipid panel before they went on the low carb diet or the keto type diet. So it kind of mimics familial hyperlipidemia, but it's antagonistic to the kind of metabolic disarrangements that you normally see with it. People who tend to have high LDLCs generally are going to have lower HDLCs and higher triglycerides, meaning that they're metabolically ill, they're potentially insulin resistant or pre-diabetic or diabetic. So the lean mass hyperresponders are generally very fit individuals, very athletic, and have lipid profiles that look horrendous to the traditional cardiologist or primary care doctor. And frequently these patients are offered statins right off the bat. So this trial was, again, as an observational trial, a little less than 600 people. It was a survey, so this isn't the highest quality data, but they're just kind of first fact-finding and then they're going to, they're developing some more trials going forward. But they're able to show that people who had a body mass index of 21 had the most severe metabolic disarrangements of their lipid profile, and also the people who tended to have a triglyceride to HDL ratio of 1. The triglyceride to HDL ratio is a rough estimate of your insulin sensitivity. You would like to see it in this 1 range. Very few patients do I see actually have it that low. It's a generally good sign if they're less than 2 to 1. If you're really insulin resistant, you see this number 10 to 1, 20 to 1. They'll have triglycerides of 300 and HDLs of 30. So it's just a marker of insulin resistance. So you can't put your hat on it that this is, you're completely metabolically healthy if you have a low triglyceride to HDL ratio. It just tells you, okay, is that possible? So where I kind of give some concern is that, patients come in, they may be feeling great, they may have lost weight on these low carb diets. And the low carb is somewhat, controversial depending on what the cutoff is. But most of the trials say that, low carb is generally less than 140 grams per day, and very low carb is less than 50 grams of carb per day. So typically these people will lose weight, they may feel better, and they're not really keen to want to give up these type of diets. But is their cardiovascular system at risk? And that's still being debated and evaluated. You'll frequently see a lot of these influencers, throw out their calcium score, their CT coronary calcium score of 0 and say, hey, I don't have any plaque in my arteries, I'm good to go. But that's a little bit misleading because the CT coronary calcium scan is a late finding by the time it's abnormal. You've had plaque building up in your arteries for maybe 10 years before things start to fibrose and calcify. So that you have a score of 0 is a good sign. You're not late to the game, but it does not mean that your arteries are not at risk of having an LDL-C of 200. You have to do further testing to really know whether the artery is at risk. And the testing that we do in my office, there's advanced blood work that looks at the lipoprotein particles. It's the particles that predict risk. The particles are made in your liver. They're like ferry boats. They fill up all the triglycerides, which is energy for the cells, and cholesterol, different vitamins and phospholipids. And these little particles, mostly the ApoB containing particles, are the ones that get stuck in the walls of the artery. If they drop off their payload into the artery, then plaque can build up in the artery. So instead of just looking at what floats in the blood, why don't you look at what's going on with the artery itself? And the first time that you have an issue with the artery is that you have endothelial dysfunction. The endothelium is the inner lining of your arteries. If the endothelium gets damaged, things start sticking to the walls of the artery. So you can measure your endothelial function by different tests that look at nitric oxide. And I've done previous talks on endothelial function, but quick review, salivary nitric oxide strips can be evaluated if that pathway is working right. Your blood pressure is a rough estimate if you have normal endothelial function. If you have normal blood pressure, you likely make enough nitric oxide. And then there's a more advanced test, a max pulse looks at the elasticity of your artery. And then there's a test called the endopath that basically gives you the percentage that your arteries can dilate when they're under stress. That tells you if you have good endothelial function. If you have abnormal endothelial function, again, things may stick to it. Things stick to the endothelium, it may get retained in the intima, which is the inner lining of the artery. If the intima starts to swell, the immune system is activated and you're more likely to develop plaque in the artery. So what I'd recommend a lot of these patients who have this lean mass hyperresponder phenotype 2 would be get a carotid intimal medial thickness scan of the artery on the side of their neck. I just did this study last week on Friday. I'm going to start doing some more Friday show and tell Q&As of these type of tests that you can do to look at the health of your arteries. But here is my score. So normal thickness, no plaque in my arteries. And the thing that I was most probably impressed by is my arterial age is 37, so significantly lower than my biologic age. So a man is as old as his arteries. Thomas Sydenham for the 1600s said that. So maybe I do know what I'm talking about sometimes, because if I couldn't do it for myself, how am I going to do it for you guys? But anyway, the CIMT, it's a great scan to tell you how fast your arteries are aging. If you have this LDL-C of 300 while you're on this keto diet and you have healthy arteries, okay, maybe you can watch and wait for a little bit. But if you're showing evidence that your arteries are on fire, you're probably going to change up this nutrition plan. Maybe you need to change up the type of fats that you're eating. Maybe you need to reintroduce some carbohydrates to the diet. I've seen just introducing some carbs or changing your saturated fats to more polyunsaturated fats or monounsaturated fats. Maybe you're going to have an improvement in that lipid profile. So again, test, don't guess. I already mentioned the calcium score test. Great, I'm going to recommend it for anybody over the age of 40 who's on this type of diet. If you have a score of 0, that's good sign. But if it's not, which I've had some patients in their upper 40s who are doing this diet and they have a calcium score of 200, that person's really high risk for somebody under 50. This is probably not the best diet for that individual, so we help modify their plan. I mentioned earlier labs, some people say, well, is this all genetic? Genetics will have a role, and it's likely polygenetic. It's rare that you can just point to one gene causing this. Again, it's not familial hyperlipidemia. It's not that they've had high cholesterol profiles since a young age. They probably had something fairly normal. They started this diet, and their numbers went through the roof, and their primary care doctor or their cardiologist freaked out. And then sometimes I get that call as the second opinion, what's going on? So the calcium score test is a good test, but there's a new test, and I recently had that test as well, called Clearly Health. It's a different type of CT scan that looks at your coronary arteries. It does require contrast, so you have to have an IV placed, and you have to get a lot more medical radiation than a normal CT coronary calcium score. So this is not a test for everybody, and it's not a test that you repeat frequently because of the radiation that you get exposed to. But the really novel test, the Clearly Health scan, it actually looks at the coronary artery walls, and it quantifies not only the degree of plaque, but it tells you the quality of the plaque. Is it fibrous calcified plaque that's not likely to cause you a heart attack? Is it soft plaque? Or is it the worst kind? Is it necrotic plaque? Is it stuff that's about to rupture and cause you a heart attack? If you have necrotic plaque, then for sure this diet is not for you at this time. You need to be, 5-alarm fire, putting that fire out. And so that's going to probably require high-dose medications, supplements, and a lifestyle change to put that fire out. So again, test don't guess, and everybody's an individual. So this test will help you determine, okay, is this plan, appropriate for you? So that's what I wanted to share with you guys tonight is, this lean mass hyperresponder phenomenon. I've been seeing it more often over the past couple of years. It's not something that I'm afraid to see. Like I said, I don't, have a reflex that I see this number and, yell at the patient, say, here's your high-dose statin. Let's, look at your health goals. Let's look at your arteries, figure out what's going on with them, and then have that conversation. Can we modify it by adding a little bit more carbohydrates back to the plan? Can we change up the fat, distribution that you're actually eating? There's blood tests that tell you how you're absorbing polyunsaturated fat, monounsaturated fats. So that's what I want to share with you guys tonight. Again, on Fridays, I'm going to start trying to do at noon Central Time, kind of a show and tell, probably 5-10 minutes max. I did one last week on the carotid scan, like what it actually looks like and entails. But we'll do it Fridays at noon Central Time. I'll talk about the max pulse at some point, which looks at the arterial elasticity. I'll probably put myself through an endopat, which looks at how much nitric oxide your arteries can release when it's under stress. I'll do the ACCOR device, which shows your essential rate of blood pressure. So I'll show all the non-invasive tools that we have in my office in St. Louis, Apollo Cardiology, that we offer our patients to look at their health of the arteries. What is the arterial age? Are their arteries elastic? Is this diet causing a detriment to their arteries? I'll put myself through it like a guinea pig and show you what it's all about. I also get frequent questions about, some of the gear that I use. What are these glasses? How does the Oura ring work? How does the Whoop band work? I'll just do 10-minute quick, like, okay, this is how I use this thing to optimize my sleep, optimize my recovery from exercise. So if you guys want to see more of those type of topics, just drop them in my comments or send me a message about what you want to talk about, and we'll do those on Fridays. So we'll open it up to any questions if you guys have any questions about the lean mass hyperresponders. But I do thank you guys for your attention and hope you guys are having a good week. I think somebody did have a question about, they're just talking about the kind of their plan, low carb winter, high carb summer. Yeah, that's just kind of the seasonal approach. So it's always going to depend on where your latitude is. You ideally just want to be eating what's growing in your local environment. That's a little bit easier said than done sometimes, but you don't want to be eating stuff that really only would have been grown in the summertime. So you don't want to eat pineapples and bananas in St. Louis this time of year. That's like putting sunshine into your abdomen, but your skin knows it just snowed outside. So you want to match up your surfaces. So in the wintertime in St. Louis, you're probably going to be eating more ketotic. All right. And then I think what I'll actually probably share on this Friday is I'll probably I won't do a cardiovascular screening test this week. I'm going to talk about a red light therapy device that I've been playing around with recently. going to be showing you guys the Carniore system. Pretty slick device. Has a printed LED that's on the back of this strip here, and it has a little battery pack that clips into it. Has different red and blue LEDs, and it's put onto whatever hurts essentially. So if you have a musculoskeletal injury or a cut, put it on there, shine the light directly into the tissue, charge up the mitochondria and collagen and everything else that the photobiomodulation helps with, and you heal faster. I've been playing around with it a little bit in a different way because, of course, I like to kind of biohack on myself first before I really talk about things, but been trying to use it to try to boost nitric oxide through the radial artery. So some of you have seen my prior Weber device that puts light into your radial artery. I'm trying to use that in a similar manner. So I'll talk about the Carniore patch this Friday at noon Central Time. I talk about photobiomodulation. So, all right. Have a question here. Does the current research show a correlation between dental plaque and heart disease? Absolutely. So, your oral systemic health is intimately tied to your cardiovascular health. So, if you have inflammation in your mouth, it's going to affect your blood vessels. And so, sometimes, having a lot of plaque on your arteries, is not the exact same as having dental plaque. But if you have periodontal disease, or you got a lot of scaling on your teeth, it could be the type of water that you're drinking. Maybe you're getting some different stuff in your water that you probably really don't want to get in it. So probably should switch up to don't drink tap water, drink spring water, glacier water, reverse osmosis water. But also can be a marker of having issues with vitamin K2. Vitamin K2 is very important for calcium metabolism. You need calcium staying in your bones and teeth. You don't need calcium to be building up in your blood vessels. But if you're developing a lot of plaque on your teeth, that could be a marker that you have an issue with vitamin K2. So yeah, definitely recommend patients see their dentist at least twice a year, and more often if there's any type of acute cardiovascular issue going on. Yeah, so I was saying good time to move south. It's orange and strawberry season down here in Tampa. So yeah, so if it's growing in your local environment, the sunlight grew it. Sunlight's hitting your skin, your gut and your skin match up, you can eat it that time of year. The one analogy too is like, if you travel, I don't know exactly if it's like instantaneous, but pretty much, if you travel south this time of year and your body's getting that type of light environment, you probably can get away with eating it a little bit more. Especially if you have higher UV that time of year, your body's able to get rid of the deuterium that's in those fruits. All right, are there any other questions you guys got for me this week? All right, I appreciate your guys' time and attention. This video is being recorded. I will put it up to my YouTube channel for those that don't watch me live. And this Friday at noon Central Time, we'll be going through a 10-minute or less kind of show and tell. This week I'll do the Carniore, that photobiomodulation patch, and future Fridays, we'll do the, I've already done the carotid intimal medial thickness, but I'll do the max pulse, the endopat, the Accor, all the non-invasive tests we have at Apollo Cardiology that look at the arterial health. So take care, and we'll see you guys next week.